with the meaning of inflammation of blood vessels is present almost in most of the disorders of the human body. Where there is a disease affecting any tissue, blood vessels are affected. But here we discuss only the disorders that start with the inflammation of the blood vessel. So, if the affection of the blood vessel is secondary to tissue inflammation or affection or granuloma of whatever kind, it's not included in this chapter. But where the inflammation, granuloma, necrosis, whatever, starts with the inflammation in the blood vessel, here we include the disease in this chapter. Just to be concise. Vasculitis, which starts with inflammation and then thrombosis follow, and vasculopathy, which starts with thrombosis due to any factor, be it a problem with the hematologic coagulation system, and then inflammation follows. This is vasculopathy, while vasculitis starts with inflammation. And to be more accurate, vasculitis includes inflammation and necrosis of the wall of the blood vessel. And here the clinical presentation shows palpable purpura and urticarial lesions. Maybe small arterioles, and here the clinical presentation includes subcutaneous nodules. Yes, maybe with palpable purpura and urticarial lesions too. But the subcutaneous nodules are here diagnostic for affection of small arterioles. Affection of medium-sized arteries will lead to skin and organ necrotic areas, with livido reticularis, with purpura, and with mononeuritis multiplex. Affection of the medium-sized arteries here of the major peripheral nerves lead to mononeuritis multiplex. Larger vessel affection will lead to claudications and necrosis of a wide area. This is very important. A dermatologist can provide invaluable assistance in the clinico-pathological diagnosis of vasculitis and in guiding patients' evaluation and treatment. Our major task here as dermatologists is to diagnose vasculitis as early as possible. In most of the cases, we are the first ones to see the vasculitis. It is systemic, affecting internal organs, may lead to death, but the skin manifestations show before anything, so we can diagnose early and seek the help and advice and cooperation of our colleagues of different branches of medicine to help the patient. Even when the diagnosis is localized cutaneous vasculitis, a systemic underlying etiology and/or vasculitic involvement should be sought for. This means what? I see the patient coming in a good general condition with cutaneous vasculitis. I should not ignore the possibility of having vasculitis affecting the internal organs like the lung, the kidney, or the mesentery. I should search for that. And even if I don't find that, I should search for an internal disorder that causes the vasculitis. I mean here that internal organ affection may be the cause of the cutaneous vasculitis, and the internal organ affection again may be part of a systemic vasculitis. Do not just relax and look at the skin lesions and treat them, ignoring the affection of internal organs. Pathogenesis of vasculitis passes through many different mechanisms. The most common case is with type 3 hypersensitivity. We see in the diagram in front of us, in the middle up, antigen-antibody reaction. This is the first step, antigen-antibody reaction, and it takes complement with it to form the soluble antigen-antibody complexes. These complexes will be dislodged between the endothelial cells of the affected venule or arteriole. This eventually leads to activation of complement 3A and 5A. These are the anaphylatoxins attracting the mast cells, basophils, and neutrophils, and leading their activation too. And activation of complement 5 through 9, leading to membrane attack complex. With chemo attraction of the neutrophils, lysosomes release their enzymes, destroying the endothelial cells, and leading to number 1, aggregation of platelets and start of a thrombus formation, and number 2, extravasation of erythrocytes. So this is what type 3 hypersensitivity immune complex mediated reaction leads to the development of vasculitis. Looking at this diagram, then we can expect what to see in the pathology. Inside the blood vessel there is a thrombus, and there is destruction of the endothelial cells and fibrinoid deposits or necrosis or degeneration of the blood vessel wall. And outside we see inflammatory infiltrate with polymorphonuclear leukocytes mainly dominating the area. It's the major effective cell here, and extravasation of erythrocytes. But this is not the only way that affection of the blood vessel, that vasculitis can happen. Type 3 hypersensitivity, yes, is the major one, but this is not the only one. Type 2 hypersensitivity with cytotoxic antibodies may attack endothelial cells. Just imagine a foreign protein, a part of a drug, being attached to the endothelial cells, and the antibodies attack. They will damage the endothelial cells, leading to the cascade of vasculitis. Type 4 hypersensitivity with cell-mediated immunity. T cells surrounding blood vessels are responsible for the vasculitis happening in Dego's disease. Type 5 hypersensitivity. Stimulatory antibodies attacking the cells may lead to vasculitis. This is what happens with the ANCA, anti-neutrophil cytoplasmic antibodies, as we are going to explain. And sometimes the antibody-mediated cell cytotoxicity again can attack. So different types of hypersensitivity can start the cascade of inflammation that ends with vasculitis and thrombosis and damage of the blood vessel wall and extravasation of erythrocytes into the surrounding tissues. Again, non-specific immunity may lead to the affection of vasculitis through the activation of complement. Complement, as you all know, may be activated through the classic pathway with antigen-antibody reactions, type 3 hypersensitivity, or may be activated through the alternate pathway with bacterial and fungal byproducts. So starting from complement 3 downwards. Again, complement 3 and complement 5, when activated, they are chemoattractant to basophils and neutrophils, and they stimulate the release of enzymes. And complement 5 through 9 will lead to membrane attack complex. Vasculitis again may occur through a non-immunologic pathway, what's called the Schwarzman phenomenon, with gram-negative septicemia or bacteremia, like in meningococcemia or sometimes gonococcemia. Release of the showers of toxins from the gram-negative bacteria will devitalize the endothelial cells, and with the second shower, a cascade of vasculitis will happen. This is what really happens with purpura fulminans with meningococcemia. So, again, we have type 3 hypersensitivity in most of the cases of small vessel vasculitis, leukocytoclastic vasculitis. We have type 4 hypersensitivity occurring with Dego's disease, malignant atrophic papilosis. We have type 2 hypersensitivity occurring with drug-induced vasculitis when the drug is attached to the endothelial cells. We have the non-specific complement activation with vasculitis induced by infection, and we have specific type with the Schwarzman phenomenon with no complement role here or anti-antibody reaction. It's the effect of toxins in purpura fulminans. Being a systemic disorder, being an affection going in the blood and in the blood vessels circulating, the blood circulating in the blood vessels. So why it is localized in some parts? We have localizing factors. Vasculitis prefers veins with slow circulation, where this gives place to margination, the blood flowing through the veins. When the circulation is slow, the white blood cells pave the endothelium, so have time to get in attachment to the endothelium and start the reaction. This happens where there is slow circulation, like with stasis, with cold, with compression for belts or such things. Location of the place, as we said, below knee is always a preferable site because their slow circulation gives time to margination to white blood cells to the endothelial cells. In arteries, when the arteriole is affected, the mechanism is a bit different. Here we have arteriosclerosis, atherosclerosis. This affects the health of the endothelium, and it helps to precipitate the reactants into the wall of the arteriole. The turbulence of flow of the blood in the arteries is high, so the areas of bifurcation are exposed to trauma of the blood flow and are more prone to have the inflammatory cells getting marginated and getting in contact with the endothelial cells. So why sometimes granuloma happens? There are factors that favor granuloma formation. Number one, the location of the reaction. In areas where lymphocytic drainage is weak, is slow, is not much active, reactants tend to accumulate. And when they are not removed from the area easily, the body tends to surround them by the inflammatory cells that ends in a granuloma formation. When the antigen is hard to digest or to remove, the body surrounds the antigen with inflammatory cells and then end up by epithelioid cells and then fibrosis and granuloma. When the antibody is in abundance to the antigen, then the balance of the immune complex is disrupted here. The macrophages cannot remove all this. Then the body again surrounds by inflammatory cells. When the phagocytic system is weak, is not able to remove all the reactants, then a granuloma occurs. When the draining system, the lymphatics, are disrupted, we tend to have granuloma. Examples of this reaction are multiple in many disorders, many dermatoses and internal diseases, not only in vasculitis. This is a common mechanism that works with the lepromas, the sarcoidosis, and other granulomas too. Unfortunately, more than half of the cases, more than 50% of cases of vasculitis are idiopathic. We cannot find an underlying triggering factor. So we treat vasculitis that we find, but we don't find an underlying cause to search for, to avoid, or to treat. Drugs, infections, and disease associated with immune complex formation like the autoimmune collagen disorders or underlying malignancy, inflammatory bowel disease, chronic active hepatitis, all are common problems that will present in the skin with vasculitis. And here, when we search for the cause, we treat the cause and we save the life of the patient. We do not just treat the localized vasculitis that we have seen. Talking about drugs, will lead us to talk about food additives and preservatives, where they work as drugs. Those chemicals are more ubiquitous and are easily overlooked. So if we find the case as idiopathic, if we diagnose the case as idiopathic vasculitis, please check if the patient is taking too much food additives, drinking colored drinks, or eating preserved foods. And the term malignancy here includes internal malignancy and the blood dyscrasias too. Factors increasing the blood viscosity as cryoprecipitated polycythemia and dehydration are less common factors, yet they are important because, again, there is slow circulation with higher possibility of margination and easier induction of vasculitis. Classifications for vasculitis are just a means to remember. You will find different classifications in different textbooks and different references. And these classifications are modified every day now and then because we discover new etiological factors, we understand more of the diseases. Some of the diseases that were included in vasculitis turned out to be, for example, lymphomas, and they were removed from the classification of vasculitis. Again, some others, neutrophilic disorders like Sweet syndrome. It's rarely now included in the classification of vasculitis. Anyhow, whatever classification we are going to follow is just a means to remember. It's a way for us to gather all the different disorders in one chapter, look at them with a panoramic view, and try to correlate between the different etiologies, pathological features, and clinical features, so we may understand and be able to help the patient with vasculitis. Anyhow, the major factor in all the classifications of vasculitis is the size of the primary affected vessel. This is the basic factor. Is it small, medium, large? Is it a venule, arteriole, or larger vessel, as we explained before? And then we may add to this base of the size of the vessel, of the type of the vessel, the major inflammatory cell in the infiltrate. The nature of the inflammatory infiltrate is the second important factor. Is it neutrophilic vasculitis, eosinophilic, lymphocytic, or granulomatous? Recently, pathogenic mechanisms are included, and now we have an entity called the ANCA-positive vasculitis. These are the famous small vessel vasculitis: idiopathic cutaneous small vessel vasculitis, Henoch-Schönlein line IgA-mediated vasculitis, the urticaria vasculitis, cryoglobulinemic vasculitis, acute hemorrhagic edema of infancy. We have the chronic form of the erythema, Elevatum, Diutinum, Granuloma Faciale, and rheumatoid nodules. All are affecting small vessels. We have vasculitis affecting medium-sized vessels. Polyarthritis nodosa is the major member of this group, with its benign cutaneous form or the systemic malignant form. We have vasculitis affecting medium and small-sized vessels. This is mixed autoimmune collagen disorder, septic vasculitis, and the one just mentioned, the ANCA-associated vasculitides. And we have the large vessel vasculitis, giant cell arteritis, and Takayasu arteritis. In this first part of the vasculitis chapter, we are going to discuss the small vessel vasculitis, mainly drug-induced. We have the acute hemorrhagic edema of childhood, with edema of the dorsa of the hands and purpura, usually of infancy. And we have granuloma faciale, it's a chronic form with eosinophils in the granuloma, affecting mainly adult males. We have neutrophilic vascular reactions like the pyoderma gangrenosum and the Sweet syndrome. Cutaneous small vessel vasculitis clinically manifests with palpable purpura. This is very important. You have to touch and feel the purpura. If the purpura is not palpable, then it's not vasculitis. If it's just macular purpura, this is most probably related to platelet abnormality or to capillary fragility. And with this palpable purpura, we can see all forms of skin lesions: macules, papules, nodules, plaques, necrotic areas with ulcers and blisters. Systemically, basically, it's a low-grade fever with malaise, arthralgia, plus gastrointestinal tract, urinary and respiratory symptoms depending on the extent of the vasculitis to the internal organs. When vasculitis affects the venules, it affects the venules that are superficial and exposed to external factors. Venules that are superficial and exposed to external factors are not just in the skin. In the alveoli, they are exposed to internal factors. In the wall of the intestine and in the mesentery, they are exposed to internal factors. Even in the glomeruli of the kidney, they are exposed to external factors. Trauma is easy here. Microbes are present and get in contact with the immune system and the blood vessel wall. So these are all liable to get the small vessel vasculitis. Histologically, as we explained with the pathogenesis, we find thrombus inside the blood vessel, fibrinoid in the wall, extravasation of red blood cells and inflammatory infiltrates surrounding the blood vessel, and leukocytoclasia. What is leukocytoclasia? It's destruction of the white blood cells in this area, with karyorexis meaning breakdown of the nuclei, leading to the presence of nuclear dust. I love this word, nuclear dust. So the nucleus here is broken down from the damaged after overworking white blood cell, and we see the nucleus as dust. Here are some photos of the leukocytoclastic vasculitis with the palpable purpura, some with papules and small blisters, all below knee, and this is the favorite part for the leukocytoclastic vasculitis. Here we see ecchymotic patches, areas necrotic, gangrenous, ulcerating. Here with the cryoglobulinemia. Cryoglobulinaemia increases the blood viscosity and ends in thrombosis and necrosis of the peripheral vessels. Especially in 30% of the cases, there is very positive clear correlation with exposure to cold. Some of the histologic pictures of the leukocytoclastic vasculitis. In the center of the photo in front of you, you see a thickened blood vessel with RBCs inside with inflammatory infiltrates surrounding. Here is more clear the fibrinoid in the blood vessel wall with the inflammatory infiltrate and with the extravasation of erythrocytes. The IgA-mediated vasculitis, the Henneckson-Line purpura, affects mainly children 4 to 8 years of old. It is provoked by viral or streptococcal upper respiratory tract infection, maybe by drugs or underlying lymphoma. It is mediated through IgA immune complexes. In all the cases of vasculitis mediated through immune complexes, if we do not take the biopsy early, we will not find the immune complexes. They are usually removed by the phagocytic system. The exception is with IgA-mediated vasculitis, the Henneckson-Line purpura. The IgA immune complexes tend to stay in the tissue for a long time. The child presents with a prodrome, fever, arthralgia, headache, abdominal pain for 2 weeks in up to 40% of the cases. There is acute onset of leukocytoclastic vasculitis rash. So we talk about again palpable purpura and the other forms of the rash, be it macules, ulcers, necrotic areas, or small blisters. Characteristic here we find the eyelid edema. With the abdominal pain, there is hematuria, arthralgia, and arthritis. Attacks last 4 days and recur for weeks. This disease may affect the life of the child. It may cause pulmonary hemorrhage, nephritis, or GIT bleeding that may be fatal if the case is not diagnosed early and treatment was taken early enough. Treatment mainly for this case, number one, is to diagnose early, and then the patient should be hospitalized and taking supportive measures, caring about water and electrolyte imbalance. Systemic steroids, dapsone, colchicine, IV immunoglobulins are all therapeutic tools, according to the severity of the case, that should be carefully monitored and observed. When we always talk about urticaria, regular urticaria, we say that the wheal never lasts more than 24 hours. Some of the references give it up to 48 hours. Anyhow, the wheals are evanescent. They disappear by themselves after some time, and if you press over the wheal, you close the dilated blood vessel, then it gets white, and if you just remove your finger again, it fills up again and becomes red. With urticaria vasculitis, there is a center of purpura that does not fade, and the lesion itself stays for more than 48 hours. These wheals are fixed, they are not evanescent, and they manifest with pain rather than itching. And when they clear up, they leave post-inflammatory hyperpigmentation. Urticaria vasculitis is a classic form of serum sickness with hypocomplementemia and anti-CIQ antibodies. These are distinctive for this syndrome, which is mainly affecting females. Urticaria vasculitis may be associated with gammopathies, Sjogren's syndrome, hepatitis C virus, and mostly with systemic lupus erythematosus. Histologically, we find the classic of leukocytoclastic vasculitis with perivascular infiltration, polymorphonuclear infiltrate, but the karyorrhexis here is minimal or absent. We don't see the nuclear dust that we see characteristically with the leukocytoclastic vasculitis. Again, since the neutrophil is the major effector cell here, dapsone is the best treatment if you find it. If not, then we may try with colchicine or steroids. Pentoxifillin will help as much as possible, since we are talking about a blood vessel affection, and other anti-inflammatories may help. Erythema, Elevatum, Diutinum. Diutinum here, the word diutinum means chronic, long-standing. It has nothing to do with diurnal variations. It means chronic. So this is a chronic fibrosing type of leukocytoclastic vasculitis. It starts peripherally and spreads centripetally. It starts at the periphery of the limbs, dorsal of the hands and feet, and spreads towards the center of the body, towards the trunk. The lesion starts as orange-colored papules and plaques with purpura and occasional nodules. When the lesions get older, they take a darker hue. Lesions are asymptomatic with occasional pruritus and maybe arthralgia in the joints underlying the skin lesions. Erythema, Elevatum, Diutinum may be associated with lupus erythematosus, with gammopathies, with HIV, with lymphoma, with celiac disease, and positive ANCA here is characteristic for Erythema, Elevatum, Diutinum. Histologically, here is very important. The damage to the endothelial cells here is slow and chronic. So we see a form of leukocytoclastic vasculitis that is rich in eosinophils and lymphocytes and plasma cells. The lesion is chronic, and we have time to attract to the area the other effector white blood cells for inflammation. Fibrosis starts, and it takes onion skin rings around the affected blood vessel. Sometimes cholesterol deposits are present in the affected area, and the disease used to be called extracellular cholesterolosis. It's part of erythema elevatum diutinum spectrum. And again, Dapsone is the treatment of choice. It starts with neutrophils, and Dapsone is very effective against neutrophilic dermatosis. Here are some internet microscopic photos for Erythema elevatum diutinum swarming with neutrophils, and you see the collagen threads, the fibrosis like in an onion rings. Granuloma faciale, it's a chronic, localized, slowly growing swelling of the face of healthy, middle-aged males. It affects nose, face, upper trunk, upper limbs, but most of the cases are present in the face. Single or few brown red. Here the lesions are darker than with the Erythema elevatum diutinum. Papulous flakes or most commonly nodules. Histologically, again, chronic leucocytoclastic vasculitis. Here we find the nuclear dust, the chirorexis, that we did not find in Erythema elevatum diutinum. Here, eosinophils are most evident in the histopathological picture. And the fibrosis is a concentric, the onion peel, the onion rings, like we have seen with Erythema elevatum diutinum. So the two chronic localized forms of leucocytoclastic vasculitis show the thickness of the blood vessel and the fibrosis surrounding them in an onion ring appearance. Here, the lesion is usually localized, so it's better to try intralesional triamcinolone acetonide rather than to give systemic therapy for a localized lesion. Cryotherapy, pulsed dye, lasers, topical potent steroids are all effective. Systemic Dapsone may be used in resistant cases with colchicine, and these are other options. But usually we do not need systemic steroids for this case. Here are some histologic pictures of the granuloma faciale, again with the blood vessel thickened wall and extravasation of erythrocytes and the fibrosis, and eosinophils are abundant in the section. Here, special stain eosinophils appear more abundant in the infiltrate. Now we finished with the first part of the chapter of vasculitis. We have been going together through the definition, the clinical picture of major sectors of the vasculitis affection, the pathogenesis, the different pathogenetic mechanisms that are included in vasculitis, and the small vessel vasculitis. In the next part, we'll go through some other syndromes and diseases under the chapter of vasculitis with the affection of arterioles and larger vessels. Thank you.